Hi, everybody. It's Dominic from Shift MS again. I'm wearing a tie today, as you'll see, out of respect really to probably our best dressed guest that we have on this. And this is Aaron Boster. He's going to talk with us in the United States, and I'm going to turn over the intro to him in a second. But I just want you to know that today we're going to talk about the future of MS care and how it's affecting us, how it affects the patients, and how it affects the doctors. And to do that, we're going to talk about it right now.
Dominic, thank you so much for having me back. It's an absolute pleasure to get a chance to catch up with you again. Thank you for arranging this cross-inter-Atlantic discussion early in the morning for me. My name's Aaron Boster. I'm an MS neurologist in Ohio in the Midwestern United States. I founded the Boster Center for MS, where we care for people impacted by MS, really with the goal of helping them live their best lives despite having the condition. I've been an MS neurologist now for about 15 years. And as we spoke last time, COVID has dramatically changed most aspects of the life of people impacted by MS, patients and providers alike.
I guess we really want to know, there's a lot of Shift MSers that actually reside in the States. I know you had the Boster MS Center there, and I was wondering what your experiences were, the way that you are having to deal with patients, the way the patients are coming to you and you're conducting the MS care. And if you could talk us around the American experience, that'd be lovely. Thanks.
I would be happy to. I would start by saying that in the beginning, I think all of us were holding our breath, waiting for it to be over. And I think early on, end of March timeframe, we were putting plans in place. They were emergency plans for short periods of time, just to get us through this couple months. And as we've all come to unfortunately learn, this COVID virus is not going away anytime in the near future. It's something that we're going to have to adapt to, not in the short frame, but in the medium term. And we are, today in August 2020, doing over half of our visits, approximately 75% of our visits are done via telemedicine. Now, early on, I was very, very excited about telemedicine, and I still embrace it. But I also have become more familiar with some of the limitations of what we can and can't see. It's interesting that in end of March, beginning of April, we were holding some doses of medicines if people were deemed to be at high risk. Not so much anymore, because they still have MS, they're still having breakthrough disease activity or progression, or God forbid, all the things that we're trying to prevent. And yes, there's still a pandemic, but we're having to recalibrate our expectations and up our levels of safety.
That's what I said to my neurologist. I want to have my MS treated instead of a theoretical potential, in this case, being a bit resistant to a vaccine, which may appear in a year's time. Treat my MS now. And I got my ocrelizumab by saying that to them.
That's brilliant of you, and I 100% agree that you still have MS, and we still need to help you live your best life. And when the viral pandemic is over, because there will be a point in time when it's over, you'll still have MS. And so we don't want to lose sight of what we know to be true. I think that you said that perfectly. There is a theoretical concern. Many patients have asked me a concern specifically about ocrelizumab. Oh no, what if I'm not vaccine ready? Well, I remind them that there isn't a vaccine yet. We don't know anything about it. And if it becomes available, the worst case scenario is we may have to wait 3 months before we can administer it. But again, those are all hypotheticals. In the meantime, you still have the disease and this drug is still working for you. So let's fire it up.
And also, I make myself, frankly, COVID ready. I think I may well get it at some point in the future, possibly, but I want to be fit. I don't want to smoke. I want to be the right weight. I want to take vitamin D. All these things which could increase my chances of having a positive outcome.
This is the best time on earth for people to quit smoking. Not just because it speeds up MS by 50%, but because it increases mortality of COVID times 14. And so if there's ever been a good time to put a cigarette down, it's now.
What are the biggest changes that you see coming into force? And by force, I mean, the changes that you think will stick.
It strikes me that many of the patient advocates here in the United States that I interact with have said, isn't it interesting that we've been asking for better access to healthcare for decades, and now that a bunch of otherwise healthy people are at risk, suddenly we're able to make all these offerings. And their point is actually very appropriate. It's my strong hope, and I do increasingly believe this to be true, that we're going to have in place telemedicine tools, even when there's no viral global pandemic. And, you know, I'll give you examples. I've done consultative visits with people from other states or other countries. Some of them are a one-time evaluation. Others are going to become long-term relationships. And we are finding a new cadence. There are people that I have yet to meet in person, believe it or not, Dom. I mean, that's kind of a crazy thought, but I've read someone's records in their entirety. I've looked at every single scan they've ever had done. I've spent 2 hours on a consultation with them where I did the best exam that I could pull off. We've put together a plan which is being executed local to where they live, and I'm seeing them remotely. That's a weird world, and yet it works great for them.
Maybe you could sum up. I've got a couple questions here for you, Aaron. One of the things is if you could sort of give us the benefits and the disadvantages for patients and for doctors or doctors, healthcare professionals about this whole shift that we've been forced into. Andy, you will excuse me. I'm dying of heat. I'm taking off my tie.
You're welcome to. I guess I would say on the pro side is that access to care has improved. So my access to my patient has improved, and their access to me, I hope, has improved. And so that's a plus. We are able to be fleet of foot as far as putting together an urgent visit. We can do that pretty quickly. On the downside for patients and for doctors, we miss we miss a touch. We miss a hug or a handshake, and we miss a proper physical exam where I can actually check your reflexes with a hammer properly. And so there are limitations in that regard. I think that if we go back to the pro list, anything that involves gaming out a discussion, talking through a therapy risk benefit, that's beautiful on telemedicine. And I might argue it's actually better than in person because there's less distractions. But I think trying to pick up a subtle finding, trying to flush out an atypical presentation, if someone's desperately trying to get me to understand and they need to show me, that's sometimes a little bit tougher.
If you were going to sum up in one phrase that you wanted to get across to people, patients in any part of the world, what's the single best thing, given we've talked about the change, what's the single best thing a patient can do for themselves, for their health?
That's an outstanding question, Dominic. It's a big question. Let me say it this way. We have to make decisions about how we want to lead our lives. And I like when I meet a family to set those down and write them down. And then we have to live our very best life despite having MS with the goal of never allowing MS to make decisions for us. And I think if there's one concept that I would like to try to convey to a patient, it's to seek out therapeutic inertia and crush it. Therapeutic inertia is a phenomenon where we identify there's a problem. So there's a new neurological symptom, or there's an old symptom that's getting worse. Someone's having an attack on a medicine, or they have new spots on their MRI, and nothing's done about it. That's therapeutic inertia. And we have to identify therapeutic inertia, and we have to fight against it. And if you could take home that one concept, I think that it would drive success in many cases, because we can find therapeutic inertia in the patient themselves or in their family. We can find therapeutic inertia in the system for which they receive healthcare. And we certainly can find therapeutic inertia amongst the practitioners. And so I would empower someone trying to live their best life despite MS to seek out therapeutic inertia, call it what it is, and fight against it.
I think you've identified just how much this is changing, how much nothing is set in stone.
And to your point, this is a fast-moving train. So very likely the next time we get together, we're going to bring all new elements to the table to discuss. That'll be a super fun thing to catch up on.
Right. Okay, Aaron, just let me say again, on behalf of everybody from Shift MS around the world, thank you very much for investing your time. We really, really appreciate it.
Thank you very much for the opportunity. Shift MS is a wonderful organization. I am delighted that I get to participate. As always, my name's Aaron Boster, and I want to thank you for learning about MS with me. So until next time, take care.